So let's make a start. Good afternoon, everyone, or good morning if you're in Cuba. Welcome to the first seminar in the Institute of the Americas 2020 to 2021 Caribbean Seminar Series program. My name is Kate Quinn, and I'm Associate Professor of Caribbean History here at UCL Institute of the Americas, and I'm co-convener of the seminar series, along with my colleagues, Professor Gad Human and Dr. Steve Cushion, who's going to be acting as the virtual doorkeeper tonight. Caribbean Seminar Series has been running in various manifestations and in various institutional homes since the 1970s, when it was founded at the Institute of Commonwealth Studies. So tonight marks a new moment in the history of the series, as it's the first time, to my knowledge, that it's been held online. In these new pandemic conditions, it's particularly appropriate that the subject of tonight's discussion is Cuba and COVID-19. And we're particularly fortunate to be joined by our two esteemed speakers, Dr. Emily Morris, Research Fellow at UCL's Institute of the Americas and coordinator of UCL's Cuba Research Network, and Professor Pedro Más Bermejo, Director of Epidemiology at the Cuban Ministry of Public Health and head of Cuba's COVID-19 National Technical Group. A very warm welcome to both, and in particular to Professor Más Bermejo for taking time out of his very busy schedule to share his experiences with us tonight. So before I hand over to the speakers, just some housekeeping and a word on the running order. First of all, please note that this session is being recorded. Also, please make sure that your microphones are muted whenever you're not speaking. And if you have a question about the talks, you can use the raise hand function, or you can type your question into the chat function. So please keep your questions short, on topic, and respectful. Our first speaker is going to be Emily Morris, who's going to provide...
But I can't say...
Oh, you're not on mute, Steve. Yeah. So Emily is going to provide a short overview of about 10 minutes before she will introduce Professor Más Bermejo, and we'll then open up to questions from the floor. And we're particularly keen to use this space as an opportunity to make connections for future research collaborations between scientists, epidemiologists, and health specialists in the UK with their counterparts in Cuba. So we'll particularly welcome questions and comments from that section of our audience tonight. So without further ado, a warm welcome to everybody, and I'll hand over to Dr. Emily Morris.
Hello, thank you very much for the invitation. Kate, is everybody hearing me okay? It's all working? Good. Yeah, I'm just going to give a brief bit of context. I'm going to talk for a very short amount of time. I just want to, just for people who are new to this whole subject, just describe very quickly about why we're looking at Cuba today. At the beginning of the COVID pandemic, I did an article, a very brief article with Ilan Kelman at the UCL disaster risk specialist. And we were looking at the case of Cuba. Both of us went to Cuba last year, talking to people who worked on disaster preparation. And we were wondering, how Cuba was going to perform. This would be a very interesting case study in this area, particularly because Cuba, of course, has the highest number of doctors per head in the world. It has a universal free health service. It has enormous research capacity, as we saw, and its disaster risk reduction and response is really second to none. They're very used to having hurricanes. They've also had various epidemics of different sorts that they've dealt with. But as we said then, that there's severe economic constraints on Cuba. There's not only the economy was sluggish even before the tightening of the US sanctions last year, which have become more and more ferocious since 2017, but particularly this year. And Cuba also, so there's been years of underinvestment. There's very crowded housing, very crowded transport, and there's also an aging population. The average age in Cuba is higher than it is in the UK. And so all of those things counted against it. And so you could see that the question was, is their disaster response and their health services and their research capacity and their capacity to mobilize strong enough to compensate for all of these challenges that they have. Now, I'm just going to very quickly just share my screen, and I just want to show you just how Cuba's performed. This chart here shows the daily cases. It's actually as a per head of population or whatever, but it shows that they had a first wave very clearly at the beginning, and actually in July reached 0 new cases one day. And so it looked like they'd conquered it. But like the rest of the world, that they were faced with the difficulty of the COVID pandemic, the COVID virus in particular, being that it lurks and then it recurs, and then you have outbreaks again. So since that time, it's returned to, well, according to the chart, same as previous levels, but you have to bear in mind that there are a lot more tests being done now than there were at the beginning. So it looks like they're still struggling to contain the virus. But if you look at another chart, this is from the Financial Times, which they have constantly updated. And this is the cumulative deaths per million. And that's by number of days since you had 3 total deaths per million. And you can see from here that Cuba is absolutely outstanding in the world. So very few countries have fewer than Cuba in this measure. So there's China down there, New Zealand, and we've all heard about these ones, not Curacao so much, but South Korea, New Zealand and China, the ones that are always talked about. But Cuba doesn't get mentioned, and it's actually doing, in comparative terms, incredibly well. This is a logarithmic scale. And here you have the United Kingdom competing at the top with the United States and Brazil. The lowest other country in the Americas is Uruguay, but even Uruguay has not matched Cuba's performance. So I just wanted to put that in there to underline the fact that Cuba's still struggling. It's still dangerous disease, but the performance has been exceptional. So this is really an opportunity to understand how that's been achieved and what has been learned by the scientists in Cuba in order to contribute to all of our understanding of the disease and the possibilities for research engagement with our Cuban colleagues. So that's all I want to say at the beginning. And so I just want to open up then now to Dr. Más Bermejo, who has been leading the Cuban response with a big team, I believe. And so it's a great privilege to have him here and a real opportunity for people to ask their questions after his presentation. Thank you.
Thank you, Emily. Professor Bermejo, you can share your screen now and unmute. Yeah, that's it.
May I?
Yeah, that's good.
May I go ahead?
Yes, please do.
Okay. Okay. Well, first, I want to say thank you very much for this invitation. I will try to show our experience in a very, very short time. That's very difficult because we have many things to show. And anyway, I will try to take a short time to show our ideas, because I am almost sure that we will have another opportunities to discuss different points, and this is just the first meeting. We will have for sure many more. Well, just to clarify, I am not the director of epidemiology in Cuba. I am working in the Tropical Medicine Institute in Cuba, and I am a coordinator of a very group of scientific people who belongs to the Ministry of Public Health, National Institute of Public Health, such as Tropical Medicine Institute, Hygiene and Epidemiology Institute, and many more. But this is a big deal to work with, and people of the University of Havana. We will show some of this point in the presentation. Well, okay, sorry. Okay. What happened here? Well, this is not necessary because Emily explained very well that. Okay, I'm going to start with the main cause of death in Cuba in 2019 and in comparison with 2018. Well, as you can see, the three main causes of death in Cuba are the heart disease, cancer, and cerebrovascular disease. And of course, influenza or pneumonia, as you can see here, is an only communicable disease that is in the main cause of death in Cuba nowadays. But the main thing that I am trying to show you this data is because the COVID-19 is a syndemic. We have many non-communicable disease in the cause of death in Cuba, and that means that we started with the COVID with this very difficult situation. And that's a very important point that I want to show you briefly. Okay, let me explain to you briefly the Cuban strategy. Well, the first thing that the cases in Cuba started in March 11 from the tourists from Germany. And the tourists from Germany introduced the disease in Cuba in 11th of March. Well, the Cuban strategy is incorporate the national way door-to-door screening for persons presenting with fever and respiratory symptoms, carried out by primary health care professionals supported by medical science students. That is a very important point because I have to say that it's the main point of our experience. Go to the field to look at case or at contact of case. And that is very important point. The second thing is the application using mobile device that they say now in Cuba, very popular, was developed for people to self-evaluate and indicate if they present symptoms, which then advise local health authority that the primary health care service provided can visit them at home. This is very important. The name is Autopesquisa in Spanish. It's available free of charge, and that is a very good point. And both components of the strategy have provided valuable complementary epidemiological information on presence of possible clinical case of COVID-19 and have opened a new possibility of surveillance and control of other diseases in the future. And going, continue with the strategy. The other thing is to gather specialists in biomedical, heart, and social science into a technical advisory team within the Ministry of Public Health. The team was tasked with periodically analyzing the epidemic situation, identifying problems, and recommendation solution for different scenarios. And we will see the scenario later on. Among other things, this facilitated incorporation of new treatment and innovation for improving patient care, as well as timely prediction useful in guiding strategies for controlling the epidemic. And the contribution of the Cuban Institution of Science have been recognized in the media by government and health authority. And I have to say that all the scientific group have a weekly meeting with the president, prime minister, and some different ministers and others, head of health institution. It's a weekly meeting that we presented some research outcomes, and sometimes we also look at the different data to help the decision do a good points and a good task. One thing that we are working from the very beginning, I mean April, is working with the prognostic models. with the researchers from the Havana University, the Faculty of Mathematics, in the dean of this faculty was in charge of this important thing, and they applied several prognostic models for the course of the epidemic in Cuba. And the third model means susceptible, infected, and recovered based on existing or ordinary, this is very important, ordinary differential equations has been used elsewhere and was chosen due to its simplicity and easy of interpretation. Now I will show you the expected cases curves, in the three theoretical possible scenarios: favorable, moderate, and critical. The active confirmed cases reported each day is registered in black. This is the first scenario according to the SIR model. And you can see the red is the worst, the green line is the middle, and the blue is was the best scenario. And the black line is the things that really happened during the beginning, it means April to August. But what happened is that at the beginning, the worst scenario means the red curve, we expected to have 4,885 active cases. And was a very, if this thing happens, was a very, very difficult situation for the health system, because the resources needed in terms of human resource, hospital beds, and so on. And this if this number of cases happens, was be on 14th of May. The second prognostic is 2,000, is the green line, 2,887 cases in June. And finally, the peak was in May, in 25 April with 847 cases. And that was very good for us to organize the health service, the personnel, the health doctors, nurses, and so on, that we need to clarify this. And this is what really happened. What is happening now? Well, you see, Emily showed the first part of the cure, and I don't want to go again with this. But what happened now is that the number of cases is almost the second wave, but we are in the second wave, and we not reached yet the peak that we have in the first wave, means 847 cases. And now the situation is getting better, because a big compromise of the government, despite the US blockade in this pandemic time, that is really, really, really very bad for us to find everything that we need for use in the people who are ill during the outbreak. Well, this is the real situation that we have on 25th of October. And you see, we have almost 7,000 cases. For us, it's a big challenge, but I know that many countries have 30,000, 20,000 in a day. But this is the all cases that were confirmed. We have that day we have 751, and recorded we have 6,029, and death just 128, means that is the real index is 1.92% of the death among the cases. It's very, very low if you compare with Latin America. If you compare with the world, that is 2.6 or something like that, it's a very, very good results according to the situation of the world. And the hospitalization and testing, we have one day, you see, we're doing around 8,000 PCR tests per day around. And in that day, 25th of October, we found 29 positive. And today we are doing 800,197 PCR tests. Means it is a lot. It's a big challenge to find money to buy everything. And we have, on the other hand, the problem with the blockade, because we have to find the real things needed to do PCR tests in different parts of the world, because it's very difficult to find. And the positive the positive test among all the people is just 0.82%. Means that it's very low. The WHO is talking that about if you have more than 5%, you are in a big problem with the outbreak. But now we have 0.82. Okay, this is one thing that I want to show you because it's a research in progress. We are looking at what is happening with the living condition index and with the number of PCR tests per million inhabitants. The line of the red line is the how many PCR we performed by 1 million inhabitants using the international indicator for these things. And you see in Havana is the capital. The incidence is higher, but the incidence is higher. We are doing more tests, and you will see in this. But the good example here is that if you look at the image, for instance, the lowest living condition have less cases than the other scenarios. But it is just new that I am just sharing with you because this research is ongoing. But the idea is just to show you how we are working, not just with the COVID itself. We are looking at another situation related with equity. That is very important in this disease. Okay. Well, this is one thing that we are calling the STARS. Means what is the preventive and therapeutic action from the screening to full recovery of the patient. We are working with 4 types of items. It's the healthy population, the confirmed patients, the serious and critical patient, and the convalescent patient. What is the Cuban approach? The first is that the healthy population not get sick. If you are confirmed as a patient, not get worse. If you are a serious critical and critical patient, not to die. And if you finally convalescent from the disease, less in long term to avoid the side effects. That is the idea that we are working with. And if you see what you are doing with the healthy population, we are doing, as I mentioned before, active screening, self-screening, biotech preventive treatment. And this is a good news that we have because we are working with our products from the biotechnological industry in Cuba. Because when this thing started, and they said, well, interferon is good, we were producing interferon in Cuba. That is a very good thing that I want to share. And the second, with confirmed patient, we have a protocol for the treatment. But the thing is that this protocol, we are using innovative treatment from our industry. We are calling about 80% of the treatment that we are using with the patient belongs to the national industry. And this is a very good news for us, because for now, with this type of treatment, we are avoiding many things that we have with the blockade, as I spoke before. And if the people are serious or critical, we are using a lot of immunomodulators to prevent the complication and even to prevent that the people die because the COVID. And after that, when the patient finishes the treatment and is in convalescent situation, where we have surveillance because we are following the patient during time, where they need a psychological support, rehab, regenerative therapy, and follow for different specialties. It means that, you know, after that they need support for not for just for clinical people, they need support from other specialties. Well, this is the approach I mentioned before. This is a Cuban population, 11,200,000. We have this is the people that we're working with as a risk, the health worker in the red zone, the intensive care unit, the dentists or ophthalmologists, and primary health care. The social institution that you know, all of you know, that is the nursing homes was a problem, and it is a problem in different countries. Spanish is one example, and we are working with all social institutions, and also in the general population, we have a stratification of the risk by territories in Cuba, means province, means municipality, and means popular council, that is a smaller government in the among the municipality. And they have this is a intersectoral approach that we are working. And also we have the selection of individual. When after we select the territory, we select the individual by age group, because all of you that this is a risk, and number of comorbidities, hypertension, diabetes, etc. Well, and this is one example. For instance, if you see the column with the aging index, the aging index in Cuba is not the same in all the provinces. We have provinces with very high index, like for instance, Villa Clara in the center of the country. And what we are doing is we have the drugs, we have stratification, and we are preparing where we have to make prioritization of the treatment, of the different treatment, and the approach and the risk approach in different countries. And this is just a map, but this map you can find how many people you have with hypertension, with heart disease, with diabetes in each municipality, even in the popular council. Okay. Well, this is the vaccine. You know that we are working in 2 vaccines nowadays. This Soberana 1 is we have a clinical trial. The clinical trial is working well. This is one example of a clinical trial. Speaking with the volunteers that they are receiving the vaccine, and this vaccine is working well according to the person and the people who are working this vaccine. They expect it to be finished in the first part of year 2021. This is good things. But now we are yesterday we started with another vaccine. This is Soberana 2, and this is another. I have to say that today we are working with 2 possible vaccines. That one of them we will find in around March of 2021. Okay. Well, this is the lesson learned during the COVID-19 up to date. It means that the things is changing, but the thing that we were doing was working from the beginning with the preparation. It means when WHO notified the situation, the action was, the first is political will, that I spoke before, the prevention of the control of strategy that we make, the government wrote a plan before we have the first case, and to organize everything, and also the human resource preparation that I also spoke before. The epidemiological surveillance was a very important dimension, facing the unknown of the disease. At the beginning, nobody, even today, the people, we have not the comprehensive view that what is happening with with COVID and what is going to happen with the SARS-CoV-2 in the future. And we have that gave to us to prepare and develop epidemiological surveillance system with the key points to identify risks, as I mentioned before. And active screen, I spoke about that. I mentioned that the highest contagious disease, the unknown prevalence of the population, and also action about the primary healthcare system, early detection of decay, isolation, critical forms and high-risk group identification that I mentioned before. Okay, sorry. Well, this is testing. I mean, testing is with the PCR, and anyway, we are working with a new test with antibodies that we will finish to use with the Cuban technology. It will be finished around 2 weeks from now. And the other thing, but we are working, is all the case are the diagnosis of a case is by PCR, no way. Now this is another thing, and also we are working with antibodies that we will see what happens in the next 2 or 3 weeks. Well, biosafety, because the problem of the virus, and I spoke about the thing that we are working with the health care people, what we are doing to provide a good equipment for primary health care, because they are not working direct in the red zone, but they are working on that. And the treatment I mentioned before, and mortality I mentioned before as well. And finally, we are spoke about equity. This is very important in the health Cuban system and the Cuba as a country, that the equity is a principle, and we are trying to keep the equity, the government, and we in the health system are doing the same. How guarantee that all healthcare servers are equitable and avoid collapse of the health system. And we do intersectoral actions, keeping health service universal and free. All these services are free for everything. And reordering the increasing of healthcare service capabilities, and testing free, and control and follow up of the confirmed and suspicious case. And finally, the Cuban response in very few words to the epidemic has been among of the more successful in terms of flattering the cure and limiting viral transmission in a relatively short time, resulting in relatively low case number and deaths. I show you everything about that. A strategy, particularly in Cuba epidemic response, including building on the universal character of the health system and is strong, I have to mention strong in capitals, primary healthcare network by carry out nationwide door-to-door screening for persons with febrile and respiratory symptoms, isolated confirmed cases, and placing the traced contact and suspected cases under quarantine. Finally, early inclusion of research and scientific institutions in the design and structure of the strategy. This is what, well, thank you very much. And I think that I have not spent too much time in the presentation. I just trying to show you what we are doing, but there are many things that we have to mention, maybe in another opportunity, or maybe some of you have questions. I will try to answer. If not, I will try to write you some of them. Sorry about the time, but I was to try very short.
Thank you very much indeed for that presentation, Professor Más Bermejo. That was wonderful, and you were perfectly to time, so no apologies needed.
Awesome.
I think clearly there are very many lessons that we can learn from the Cuban case. And I was particularly impressed with the slide that you showed on the preventative and therapeutic actions with the population divided into 4 groups, from the healthy population to the serious and critical patients and so forth. So I'm going to open up to questions from the floor. I wonder perhaps if you could stop screen sharing your presentation, and then I'll be able to put it into gallery view. And those of you who have questions, I'll do my best to see you with raised hands in the participant function, or wave your hand at me. So I see one hand up already. So that is a question from Susan Mitchie.
Hi, thank you, Susan Mickey.
Sorry.
Great presentation. I'm Vice Chair of Cuba Solidarity Campaign in this country, and I'm also on the government's scientific advisory group in emergencies, advising on behavioural science in relation to COVID-19. Fantastic what you've achieved and what you're doing. I was particularly interested in what's happening in relation to educating and supporting people on the basic kind of protective behaviours of keeping physical distancing, making sure there's really good ventilation indoors, making sure surfaces and hands are sanitised. So who's responsible for doing that? What kind of methods are you using? And what sort of impact do you think that approach is having in the population? Thank you.
Thank you.
Well, hello, Susan. Thank you for your comments. But you are asking some question about clinical issues, as I understood, or not?
Well,
you
really
talk about ventilation?
More preventive behaviours in the population.
Ah, okay.
You know,
okay. Yeah, get it.
You know, getting air into indoor spaces,
yes, get it.
disinfecting, etc.
Yes. Okay, thank you for clarifying. Okay, well, Susan, yes, there is a campaign. There is a campaign in the mass media, a big campaign in the TV and radio, and of course, social media. And we are doing a lot of work in this sense. For instance, just to take what we are doing daily in terms to keep the population well informed. First, we have a national a TV press conference by the National Director of Epidemiology every day from 9 to 10 p.m. AM in the morning. And then they explain what is happening. I mean, not technically, but for the population, in order that they know what is the test, what we are doing the test is we introduce some change in the protocol. He explained previously what we are doing, some change, and this is very important. And all the people follow this like a series, because they offer daily how many cases we have today from which province, which municipality, how many cases we have with the I mean critical case, how many people die from different part of the country, in which place they die, what they die, how old as he or she, how many risk factor of comorbidity they have, and this is a point. This is the main point. I mean, and this press conference will be replied in different times in the day, in order that the people are not available at 9 p.m. at 9 a.m. They can see in other plan, and all the information when he finish appears in Infomed webpage. All the information, very transparent. All the information is there. The only thing that we, of course, we are not giving for instance, the name of the people, just how many people, where they are living and so on. Well, this is one thing. Another thing, the meeting with the president and all the minister board is transmitted by TV in the national news at 8 o'clock in the evening, and they explain what they spoke or speak during the meeting, and what are the new approach of how many things we have to do to change. I mean, for instance, because one thing that I didn't mention before, but I have to say that we have some problem with food, because this pandemic came in the same moment that we have a economic situation, difficult economic situation, because of embargo, because many things that I mentioned, but they spoke. I mean, the government, maybe the president speak about what happened, what we are doing, what is the sectoral approach that we are doing, because we have this problem. And also we have the weekly conference of the Minister of Health, speaking about how the Minister of Health is doing things specifically in treatment and so on. Also, the meeting that I mentioned with the president weekly, with the scientific committee that we are working, and they reproduce the meeting in national TV, in not the meeting as a whole, just the main things of the meeting. And then in the Cuba debate, you can see it if you want it, they prepare a big and detailed information about what happened in the meeting, what the main thing that was threatened. This is one thing. We'll see the official information. And also the networks, the social media have different pages, Facebook, LinkedIn, Twitter, that they transmitted information for the population. This is one thing. Another thing is, I mean, this is a mass media as a whole, but all the primary health doctors have information daily to share with the population. And they do this, what specifically happens in one neighborhood, in what block, or when one province have a special situation about the outbreak, they have a provincial channels that they give to the population of this province what is going to happen in the, for instance, now we have a problem in Villa Clara, and the TV channel in Villa Clara explain to the population that is happening. Also, we are hoping in the psychological things to prepare the population, because all of us know that this is a very problem from the psychological point of view, and this is another thing that they have support. But meaning that there is one integrated approach in the terms of education, in terms of the how many things are on the table about the pandemic, is working well, because the population knows very well what happened daily, what happened in her neighborhood or in his neighborhood, what happened in the I mean, different news that they have to know about the I know if you are happy or you need more information. Are you happy?
Thank you for that. We have a lot of questions coming in the chat, and also a few hands raised. So I'm going to summarize some of the questions that are in the chat. So this one is from Hamish Mohammed. He thanks you very much for a great presentation that highlights the success of the COVID-19 control program in Cuba. And he asks, I think you've already addressed this, but how did you amend your surveillance systems to capture COVID-19? And how well has the population complied with social distancing guidelines? And were people required to self-isolate at home? Sorry.
Social distance? No,
how well have people
social
complied with social distancing?
The first was?
Were they asked to self-isolate at home after being diagnosed?
Okay, and the third?
So this is from Audrey Prost asks, so she says, in the UK, less than 20% of people self-isolate after developing symptoms. What have you found most helpful in supporting individuals or family groups to isolate? And that relates to a question from Maria Ines about overcrowding. So what's been most helpful in supporting individuals or families to self-isolate? And in the context of an overcrowded population such as Havana?
Okay. Well, let me start with we are Cubans, we are Latinos. The weather in Cuba today is 32. Means that to stay at home is very difficult. But I have to say that the people in general were following the rules very well about the stay at home and all these things. And this is one thing that I have to say. We did it. I mean, we did it. We don't have problems. I mean, small outbreaks in bars or restaurants. This is not that thing was was not a problem to us. But yes, means that. In summary, self-isolate in Cuba, we did it. Not as well as we decided, but we did it. Social distance is very difficult because it's checking hands and kids, friends and people is very often, but the people follow the rules. I have to say, I have not to say 90%, but we did a good job because the helping of the mass media in the different message for the general population. The other thing is that you are telling that 20% of the people in UK are not following the self-isolated, or just 20% follow the self-isolated. That's true. 20%.
Less than 20% of people.
Less than 20%. Okay. Well, now, because I explained what happened before today is before 10th of October. After 10th of October, because we have a number of cases that we can manage at home. We decided to isolate just the cases, confirmed cases in hospital and suspicious cases in a special center for isolation. And we decided, because it's better, stay at home with the family. If we have a case now, I mean, a first order contact of one case, they stay at home. Before, they stayed at the special isolation center. And yes, it's better to stay at home. And the people here that they as average, they stay at home. But even if they stay at home, the family doctor is in charge to be sure that they don't move, that they stay at home. And for this reason, the government supply food and different services that they need, food, drugs, different things that the people need daily. They have a special team of supporters that they bring to the population, food, drugs, and different treatment that they need to do this. And of course, for instance, now we still have in Havana, the schools are closed because Havana, in this, the second wave, Havana had a big number of cases, and the government decided to open the schools in all the country except in Havana. And they are going to start the 2nd of November. It's just 3 or 4 days, 5 days. And now we are preparing for this. But I am talking about this because education they are preparing a special information program that the Minister of Education is working on that. Are planning, the minister are planning to introduce a special education tips in all the school at different level, primary level, secondary level, and university level as well.
Thank you. I will summarize the next set of questions from the chat.
Okay.
So there's two from D. Delange, who says, your approach is most impressive, especially that no one is left alone. I think you've addressed this already, but he or she asks, what happens on the door-to-door if people need support? And also, how did the experience of working with Ebola patients in Africa influence how you deal with COVID-19? And a question from...
Sorry, what happened with Africa? No, door-to-door, okay, I get it. Second.
How did the experience of working with Ebola patients in Africa
okay, I get it.
Influence how you dealt with COVID-19?
Okay.
And finally, as Emily mentioned, Cuba is up against resource shortages. Have other health services such as cancer treatments suffered as a result? And with a great suggestion that we need to send our health minister to Cuba to go and learn some lessons.
You're welcome. Well, door-to-door is one part of our approach, but it's not too easy. I have to mention it's not too easy because first, at the beginning, we have to speak many times with the primary healthcare doctor, saying to them, if you are following this protocol, you are not at risk at all. And we evaluate this. And I have to assure you that we have not cases that the people who were working door to door during this time. This is one. But the second with the door to door is that is very difficult because it's not just to go inside the house, no? It's just to stay at knock at the door and say, well, we know that here you have people at risk, and he's diabetic. They have everything for the treatment. They have a fever. They have anything that they need. It's not just to ask about the disease. It's about the comprehensive situation of the family. And this is one thing that opened the door. And the third problem that we have, we opened the door that they started to write in a paper, you know, and when you have to write the paper from 20, 30, 40 houses, it's a lot of paper. And we spoke, I mean, the Minister of Health spoke with the group of informatics, and they prepare a APP in the phone. And they have a map with all the house that you have in your place, and they did everything with the phone for free. It's a deal with the Minister of Health and the Communication Minister, and this point helped to us a lot that the people do this. This is about door to door. What? Well, we were working in Ebola. Yes, we were working in Africa and with through WHO is. And by the way, we were working I think that this is the first time that we were working with some doctor from the US together. It was a very good experience. We started there for, I mean, a brigade there was for around 3 or 4 months. And we have one people who was sick, but finally he recovered without problem, and it was a very good experience. But and not all also with Ebola, we were working in Africa with dengue, with malaria, with typhoid fever, with many things, many communicable disease that they are very often to find there. And we have this experience. This experience allows us to improve because we are not in Cuba. We have not experience to work frequently with the communicable disease because the cause of death and the health situation in Cuba, but because this experience, when the doctors come back to Cuba, they have experience even in diarrhea, in different things. And this is a good experience. We were working in Ebola, and we know that we have experience from different countries in Africa against different communicable diseases. About the health service, yes, we have to stop different health service. Now we are reopening step by step. From the 4 weeks ago, we are reopening the service step by step. But because some service we have to keep some service, like for instance, cancer treatment, let me see, surgery, urgent surgery, and different things. But the service, the normal service decrease at the minimum, and just keeping the urgent service and some service well defined. But since 2, 3, 4 months ago, we are reopening the service, and I think that in 1 more week, all the health service starting to working as before.
Mm-hmm. Thank you. Miriam has a question. Miriam had your hand up for a long time, so if you want to unmute.
Yes,
right
I just written because I thought I was not going to have time. It's very quickly. We know the success in Cuba in test and tracing, and also in the daily presentation, as you mentioned by Dr. Duran, he also explained how many of the positive cases daily came from those that have been traced from the testing system. And my question is that, what is the reason that they managed to keep this control of those that contacted the positive one? Or is that have to do with the keeping those contact to the positive in hospital or in facility of health at the beginning?
You're very familiar with Dr. Duran.
Yes.
Okay. Well, you know how they are he's doing a very, very good job, really. We are friends, but he's doing a very good job. Well, the answer in short is that 80% of the new case came from the contacts of cases. 80%. 80%. That's the main source of the cases that we inform every day are from contact case. Contact case of first degree means that there's a contact rate, family, workers, and so on. This is one thing about the second thing we were trying with population studies, but population study is very difficult to find cases because I am not sure, because nobody knows what is the real problem. The real, because the asymptomatic case, many things, nobody knows how many, what is the real, at least that you are able to prepare a zero prevalence study that, for instance, Madrid did that, Spanish did that. But we do one, but it's not finished yet. It is in the fourth stage. Well, means 80% comes from first degree contact, and the other 20% is from population studies. But we have to start the population study. Why? Because we are doing the population study with PCR. Means that, you know, that I don't know in the UK how much cost, but the cost here in Cuba for each PCR is about $50, 50. And if you prepare a population study to detect a positive case, and you have to use, let's say, one example, 1,000 PCR tests, and you detected, let's say, 20, you have to spend a lot of money. But it's not just to spend a lot of money, because it's not 20, it's less than 20. Even 3 cases, 4 cases. And that is why what we decided 2 weeks ago, that we are going to start now with the antibodies test. And the idea that we have in our mind is that we are going to perform a antibodies test. And if you, for instance, in one, let's say, in one school, and if you find that you have, let's say, 50%, is very high, but 50% that the case that had the COVID before, because EGM and EEG, you have to say, well, here we have to go with a PCR, but with the sample, not with the population ahead. And this is one thing that we are doing just now. We have to present this next Friday. When I finish, I will send what is the design.
Thank you. We have a question in the comments which asks, what is your biggest concern moving forward?
Concern about?
what is your biggest concern for the future, for the moving forward?
With living forward. Well, the biggest concern is we have a control, but I am not sure that the control is absolute. I am not sure. Because the virus, because the Latinos blood, that when the people in the street, but everything is under control. Don't worry. I mean, the people who die is just the old people. It's not I mean, it's a popular phrase, and but anyway, the future will be very difficult because first is the blockade state, and it's a big sacrifice to buy all the resources needed to have PCR and every day. How many we have for tomorrow? No, we have 3,000, but a chip will be here after 3 days. This is the pressure that we are working every day. But the future, I am almost sure that the outbreak is not finished yet, because you are not isolated. We are going to open the airports. We have to open the school. We have to open all the provinces, because we have to, some of the provinces that I mentioned are closed. We have to open the national movement, and we have to open many things. Because it's the life, and it's a big risk. And another risk that we have, that all of you know, that the Cuban Americans is that who are living in the U.S. are coming in the Christmas time, and it's a big risk. And we are doing now, but this is we are doing now. All the people who come to Cuba have to, in the airport, we are performing a PCR test. At the other day, we have the result. And then, meanwhile, they have to stay at the hotel, at the house, and this. But I'm not for how long time we will able to keep this thing.
I'd like to ask a question, if I may. This is the Caribbean seminar series. So I wanted to ask a question about the help that Cuba is extending to sister Caribbean nations who are also having a difficult time confronting similar issues with tourism and opening up airports while not having the same infrastructure and capacity as Cuba has.
Yes. Well, as far as I know, we had in the Caribbean around 3,000 of medical doctors helping this small country. It's around, no, it's not the, but it's around 3,000. And we were working there. They are coming back because the situation in all those countries are under control. It's under control, but yes. We have this capacity, and you know the U.S. government have a big campaign against the Cuban doctor. That is not true, but even this campaign, the country have to use our human resource to do that. And one another thing that I have to mention, because it was impressive at the beginning of the outbreak, when one cruiser with the UK citizen, we opened the door in Cuba here at that time in March, I think. It was a very, very good operation that they prepared, that the people have to come to Cuba, enter to Cuba, and then take a plane to be back at home.
Fantastic. Thank you very much. I think I'd like to bring Emily back to, if you want to say anything, Emily, about taking forward some of the collaborations that might be established between the Cuba Research Network at UCL and our colleagues in Cuba. So if you're there, Emily, and then...
Yeah, I'm here. Can you hear me all right?
Yeah.
Yeah, no, yeah, the idea of, well, I'm very pleased that we've had you here, Professor, to talk about the work that you've been doing. And I think we've had a taste of what you've been doing. Like you say, there are so many other questions. There are so many contrasts between the way that you do things over there and the way we do things over here, and things that we can learn by having, bringing scientists together. The UCL Cuba Research Network, the idea is to do collaborative research, which is generally led on the Cuban side with the UCL people. We find partners for Cuban projects in which UCL people might want to be involved, or other people from other universities as well have been involved. And so what I'd like to do is to keep the communication open. You did say that you would receive written comments. I do realize that you must be absolutely, like you said, this is a very delicate time. You're opening up to tourism. Things are very difficult. But if we could establish a network between the two sides, it might be a useful thing to do to exchange information and so on. I do know that you're very active in working with the Pan American Health Organization and so on, so you're internationally linked anyway. But I think that UCL is, well, the UK has enormous research capacity, and sometimes I think that they're not fully aware of what we can learn from the Cuban case. So if we can keep those channels of communication open, I think that'd be very good.
Thank you, Emily.
Emily, sorry, just a minute. We are more than open to keep collaboration. I have to mention that we had a very good collaboration. Even I was there for about 3 or 4 times in the Liverpool School of Tropical Medicine, London School of Tropical Medicine, Warwick, different places we had a good collaboration to train people, to take people here, and even to receive students from master and PhD degree here from different universities, and we are open any collaboration. And I have to say that keep in touch, please, and anything that you need, I am ready. I am ready. And we are ready. I am talking about the Cuba. No? We are ready.
Yeah. Okay. That's great. That's great. Thank you.
Thank you so much. And thank you, Emily, for organizing this, and especially to Professor Más Bermejo for sharing your very valuable time with us in the middle of this pandemic. And I think, as one of the comments in the chat says, we need to be sending our government ministers over to Cuba to take some lessons. They've spent billions on a test and trace that doesn't work. And you have a free app, door-to-door, tracing everyone. And we have a lot to learn. So I want to thank you again for your time, and un gran aplauso from the virtual world for your wonderful presentation.
Thank you very much. Thank you very much.
Thank you.
Thank you. Thank you. Well, keep in touch.
Yes.